We will now finish off with a few miscellaneous conditions and start with subungual hematoma. This is a closed nail bed injury with hematoma forming under the nail, creating increased pressure and pain in the closed space. This results usually from a crush or compression injury. Differential diagnosis would include fracture of the distal phalanx and IP joint injuries. X-rays should be completed to rule out fractures and avulsions. Symptoms are usually relieved with drainage of the hematoma. This is usually performed by drilling with a sterile needle of around 18 gauge or perforation with electrocautery or heated paperclip through the whitish lunula in the proximal nail. Nail removal, drainage, and incision with nail bed repair is considered if 50% of the nail bed is involved or there is partial nail laceration or avulsion. The next condition to review is acute compartment syndrome. This results from increased intra-compartment pressure caused by swelling, bleeding, or other space-occupying lesions, and may cause progressive vascular, neural, or myofascial structural compromise. If left untreated, this can progress onto Volkmann's ischemic contracture, which is irreversible from myonecrosis. There are 10 compartments in the hand and 3 compartments in the forearm, which may be involved. Mechanism usually involves close compression crush injury or open stab or puncture injury. Fractures are the most common cause. You can also see this with iatrogenic injury from tight casts and dressings. Findings may initially be vague and subtle and may not present until late. A high index of suspicion is always required. Compartment syndrome should always be considered in injuries of the hand and forearm. Findings on physical exam should include the 6 P's, which are pain, pallor, paresthesias, paralysis, palpable swelling, and loss of peripheral pulses. X-rays should be ordered to rule out fracture, and compartment pressure measurements, if possible, should be done if they do not delay emergent operative intervention. Absolute pressure greater than 30 to 45 millimeters of mercury, or 30 millimeters of mercury greater than diastolic pressure pre-anesthesia, often called the delta pressure, would indicate emergent operative treatment. If the delta pressure is below threshold, then careful monitoring with repeat pressure testing is indicated. Treatment is performed to reduce swelling and to maintain blood pressure. Hypotension exacerbates tissue ischemia, and relative hypertension provides some protective margin. If in doubt or above delta P threshold, then emergent fasciotomies are indicated. The next condition for review is chronic regional pain syndrome. This is chronic pain syndrome resulting from abnormal autonomic activity secondary to an injury. Pain is usually out of proportion to physical findings. It is classified as type 1 if there is no anatomical nerve injury, and type 2 causalgia if nerve injury is present. The mechanism is autonomic dysfunction and chronic pain triggered by an amplified response to injury, such as a sprain or fracture, surgery or prolonged immobilization, or delayed inappropriate treatment for injury or pain. Differential diagnosis would include chronic compartment syndromes and other chronic pain syndromes, as well as yellow flag conditions. Physical findings would include pain in excess of expected physical findings, swelling, stiffness, and skin discoloration with trophic changes. Often you will see hyperhidrosis and altered vasomotor response. There are two phases. The acute phase is hot and seen in the first 3 months with pain, redness, swelling, warmth, and hyperhidrosis. There's a positive bone scan. The subacute phase runs from 3 to 12 months with increased pain, cyanosis, dried skin, stiffness, and skin atrophy. Osteopenia will be seen on x-ray at this point. The chronic phase is greater than 12 months, and there's decreased pain, fibrosis, and cool, glossy skin. There will be less hair formation, and joint contractures may appear. Extreme osteopenia will be seen on x-ray. Imaging would include x-rays, bone scan, and thermography is sometimes done to check for hot or cool phases, but is of questionable utility. Nerve conduction EMG can be used to assess for nerve injury in CRPS2 or causalgia. In management of CRPS, diagnosis is key to improve outcomes. Chronic pain management protocols are followed, and treatment modalities are offered to provide positive stimuli. These would include physiotherapy, massage, and acupuncture. Multiple medications have been used, including NSAIDs, alpha blockers, antidepressants, anticonvulsants, calcium channel blockers, GABA agonists, and if they are not helpful, then nerve stimulation and chemical / surgical sympathectomy and surgical decompression are considered. The final condition to cover today is referred pain. Pain is referred from proximal structures and may present in dermatomal, myotomal, and sclerotomal distributions. You will also see non-typical presentation with visceral distributions. Central hyperexcitability is important in the extent of the referred pain. You will often see proximal spread in referred muscle pain, and it's most often in the ipsilateral side of the pain. There's often modality-specific somatosensory changes, so there is a need for multimodal sensory exam. There can be nerve entrapment at multiple levels, including the nerve root, brachial plexus, and peripheral nerve. This results in dermatomal or nerve distributions, myofascial trigger points, or bone fascial injuries may present in atypical patterns.